Welcome back to the Sports Docs podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine with experts from around the country. In this episode, we're going to continue our discussion with Dr. Brett Owens and focus on treatment of isolated and combined MCL injuries, as well as safe return to play.
Our conversation picks back up with a Level 1 prospective multicenter randomized controlled trial from March 2022 issue of AJSM, titled Comparative Outcomes Occur After Superficial Medial Collateral Ligament Augmented Repair versus Reconstruction. 54 patients with grade 3 MCL injuries were randomized to either MCL augmented repair or MCL reconstruction using a free semitendinosus autograft. At 1 year post-op, there was no difference in objective outcomes, including gapping on postoperative valgus stress x-rays. However, patient-reported outcomes such as IKDC and Lysholm scores did favor reconstruction.
We finish up today with an article from the March issue of AJSM this year titled Nonoperative Management, Repair, or Reconstruction of the Medial Collateral Ligament in Combined Anterior Cruciate and Medial Collateral Ligament Injuries. Which is best? This systematic review and meta-analysis investigated the outcomes of 3 different approaches to ACL-MCL combined injuries. ACL reconstruction with either 1. Non-operative treatment of the MCL tear, 2. MCL repair, or 3. MCL reconstruction. There was no difference in patient-reported outcomes, range of motion, and quadriceps strength at final follow-up. The rate of arthrofibrosis was similar between non-op and surgically treated MCL injuries, and the authors note that this rate has steadily declined, likely relating to advancement in surgical technique. Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allografts starts with JRF Ortho. To learn more, visit jrfortho.org.
Well, I think, we can shift our conversation now to treatment options for MCL injuries. So before we dive into our next paper, it's going to talk about different surgical techniques for MCL injuries. We want to chat a little bit about how you make that decision between non-op and surgery. So if it's an isolated MCL tear, how are you deciding between non-op and surgical? Obviously it's less common, but what pushes you towards surgical treatment?
Sure, like I mentioned, the tibial-sided injuries I'm a lot more aggressive on, and those can have a slower and less reliable healing. And high grade tibial-sided injury, I usually fix that acutely. Certainly, if it's flipped back or if it is flipped on top of the pins on the tibial side, I will usually fix that. Similarly, if it's a femoral-sided injury as well, an avulsion, and it's flipped around and doesn't look like it's going to be in position to heal in, that's when you can make a very strong argument for fixing acutely. However, I'd say that it's pretty rare to see that in an isolated situation, these high grade injuries. It's usually with a concomitant ACL, and so there you're talking about the doing usually a concomitant ACL reconstruction.
Yeah.
That makes sense. So can you walk us a little bit through, we'll get to surgery in a little bit, which is the fun stuff, but can you walk us a little bit through the non-surgical treatment? You kind of touched upon it there, you get them back to play in a brace, but how long are you restricting weight bearing? How long are they in the brace? When do you start PT? Kind of all that stuff.
Yeah, I mean, it all depends. Like we mentioned, these low grade injuries or grade 1 injury, usually they're able to weight bear as tolerated. You can pretty quickly begin ramping up their activity, usually in a brace. I use a single upright brace Usually, the grade 2 injuries, if you can have a short period of immobilization, I think it can be helpful. If you can use a long hinge brace, crutches, get them off it for a tiny bit, even that first few days to week, I think it can be really helpful. Unfortunately, and it's great when you're able to see that athlete on the sideline and manage them throughout. In the office, oftentimes they're coming in and it's been a week or 2 weeks, and it's hard really to go backwards at that point. Usually, the key is working closely with the trainers and understanding what you can kind of get them back to. I find it to be very helpful to use a single hinge brace, or sometimes even an unloader brace. So in this case, it would be a varus producing unloader that can allow them to be a little bit more active, get them on the treadmill, get them maintaining their aerobic conditioning to allow them to be ready for return to play. The key is working hand in hand with the trainer. And return to play considerations, that's always a little bit tricky. It has a lot more to do with where they are in their season, what position they play, what their demands are. In addition to having no pain through on physical exam, I think having some sort of functional test. In the office, I use a fair amount of functional tests. I'm always having people running down the hallway. My couple of partners that see in pods next to me are always making fun of Owens. His patients are always running and cutting and pivoting in the hallway. But I'll have them do a karaoke, which is about as hard as I can usually get them to do on MCL, at least on the. So it would be basically the swing leg, the back leg behind on a karaoke. Have them do a couple, and that's a really good test you can do in the office or on the sideline just to see how their MCL is with that little bit of rotational and swing phase. As you know, the skill positions are a little bit harder to get folks back. Usually interior alignment, usually you can get it back a little bit faster in a brace.
Yeah, no, I like that test. My clinic recently sort of combined with a total joint clinic, instead of the day the clinic is just sports. And it's funny because you see that sort of thing. We have in my clinic, in my space, there's force plates and a biomotion camera that we use daily, where people are doing drop jumps, doing all these sort of things, running around the hallway. And then
the walkers. Yeah.
New sound that's what is this? But so it is very funny. So I'm sure the total joint guy is what are you doing? And I'm just, what are you doing? That noise. It's terrible. But anyway, no, I like that test. That is not something that the karaoke, that's not something that I've employed. It's something I feel like I always had as a kid. It was part of your warm-ups and your whatever. But so I like that idea of doing that test. So I can't remember if we told you that when we post things on YouTube, we put in graphics of things the physical exam tests or the stress radiographs or whatever, just because we do get a lot of different people, whether it's physical therapists, personal trainers, or surgeons, kind of listening. So we'll put in that graphic. So it's clear. Maybe we'll make Ashley do it and do a little video of it and, put that there.
I'm gonna say, should I admit here again that I don't know what I get when you're doing this. I know what it is. I just didn't know that was the name. And but you know what I'll do? I'll make the video. I'll dance around my living room and I'll post that. It'll be great.
Hold you to it.
Awesome.
I think that's very helpful, because trying to figure out when are they ready to run, when are they ready to cut. It's hard, I think they want a specific time, and it's just kind of testing it out and pushing their edges and seeing if they're ready.
Catherine, I wanted to ask you, do you do any, because we've talked a lot about return to play testing and things. Do you do any specific, we kind of talked about that karaoke and things like that. Do you do any biomechanical testing to make sure people are good to return to sport after something like a non-operative injury to the MCL? And sure. What are you looking for as some of the most common deficits that you're seeing when you're doing that? Is it balance? Is it weakness? Is it a combination?
I generally do. So Brett, in my clinic, there is a fair amount of functional movement testing. So the force plates can obviously look at symmetry. So when you're doing a squat, or if you're doing a drop jump or a jump squat, we can see like, are you sort of avoiding that side? Psychologically, are you ready to sort of take load over there? Are you still like have these compensatory patterns with like landing techniques? But then the camera will tell us like, oftentimes I'm not seeing much when they're doing bilateral activities, but if they're, doing single leg squats, those types of things, like, are they dropping to valgus? Are they not activating their glutes? Doing all that sort of stuff. So I think it's more of just like almost going through like a functional movement screen that I'll do with some of the non-ops that are higher end athletes. But the majority of the testing is definitely post-operative.
Yeah, I think that's really interesting because something we're trying to do with my local PTs is trying to come up with return to play testing protocols for most injuries. Like we've talked about shoulder instability and how that's really lacking in the literature. And so I just use the ACL one for like my meniscus repairs and for MCLs because a lot of it is very similar, but it would be interesting to see if there's literature or if there's not to study to see what is maybe predictive of re-injury or what are the most common deficits, as you talked about, that kind of falling into valgus, weak glutes, all that stuff, so I think that's very interesting. Yeah.
While we're talking about non-operative stuff, I don't do a lot of this, but another thing I would add is I do sometimes use PRP for I'm a big PRP guy, but this is one thing that I think it can be helpful, especially in I would call it an MCL that kind of falls out of the hot phase of injury and it's kind of cooling off, and you're just not getting the healing that you want, and you still have symptoms at the site. I think sometimes it can reinvigorate a little bit of the healing process. You do have to slow them down afterwards, right? And kind of, take a couple steps back and re-brace them in the early phase and kind of restart the clock a little bit on it. But it can be, especially for an in-season person, if you want to have that hope maybe to get them back, you sometimes can have success with that.
Yeah, and I think that's also, you bring up a point about after PRP, I don't think we have a lot of guidelines or a lot of really data to talk about like what activity is okay after, like how fast can we get them to return, no matter what it is, whether it's like, someone's doing it for cuff or tennis elbow or whatever, like, are we supposed to be shutting them down? Are we letting them just listen to their symptoms? But I think that there's a big gap there of trying to figure out the activities after that.
Truth.
Okay, so we need to hear, Brett, we haven't heard, like, what is your repair technique in an isolated MCL? So say it's like a grade 3 MCL, you've decided that it's something you're going to manage surgically, like a proximal injury. What's your repair technique and how has that changed over the years?
Yeah, I don't know. That's one thing I don't think has changed for me. I usually use a double loaded anchor. On the femoral side, it's usually a single anchor. Double loaded anchor, more of a cuff anchor. At the origin, just south of the epicondyle. And I usually use a single anchor, which I incorporate MCL and POL on that side. The tibial side is where I usually use multiple anchors if I can. Also try to get double loaded anchors and get a broad footprint on the proximal tibia. But I don't think there's anything too fancy about my repairs. Teach me something. Well, what you got, Ashley, for your repair technique?
Yeah, so very similar. So I do most of the ones I'm repairing are the tibial sided ones where they're flipped up on themselves. I just had recently, a couple months ago, a lineman who actually was wearing a prophylactic brace and was just taken out at the knee. I was shocked his cruciate ligaments were intact. And he had just a complete avulsion of his tibial attachment of the MCL, deep and superficial, kind of bunched up on itself. A big lineman, normal alignment, but I ended up taking him for repair. And I did the double row repair. I did 2 fiber tacks that I passed through and then tie. And then I bring them over the top and dunk them into 2 distal swivel locks that then I incorporate a running crack out in the superficial MCL into that. So it's like almost like a rotator cuff. It's like a double row repair. And then might be controversial, but I do add an internal brace to these. I've learned over the years to really make sure I'm not overly tensioning the internal brace, because I think stiffness is a real concern. I feel like the first couple MCLs that I did, I definitely cranked, because I try to crank on everything and maybe made them a little bit too stiff. I don't really know that you really need an internal brace, but I think it just gives me a little bit of comfort, kind of advancing the rehab maybe a little quicker, having that internal brace in place. But what are your thoughts? Do you use an internal brace, or are you not a fan of the internal brace?
No, I haven't seen the data really to support it on an MCL. I mean, it's got some really good data on UCLs, and I think it's cool. There are studies that I know support it for as an augment to an ACL. I'm kind of a BTB surgeon most of the time in these young athletes, and I haven't seen data for that really. I know some soft tissue graft folks have found some value. I don't know. I think it's a really cool concept, especially for a mid-substance type tear, and you're trying to, maintain the relationship, right, and allowing things to congeal and heal in. I think in the scenario that you just, I mean, gosh, actually, what a repair, right? You have a double row repair, right? I mean, and that's really good tissue, right? And so, do you really need something else to make you feel better about it, right? I mean, do you need one piece of a non-absorbable tape is going to make the difference? I don't know. I think if I'm feeling insecure about it, I'm adding a graft. I'm probably adding an allograft to it, or even an autograft, right? And some folks will use ipsilateral hamstring right there. And early in my practice, I did a lot of that, but I pretty much moved to allograft most of the time now. But I think if I'm feeling not good about it, I'm probably going to add a graft. And you can make a good argument, I guess, too. If you're adding a graft, you could add a suture with that graft. I still usually use just the tissue itself. But it's a good point, Catherine. Are you drinking the Kool-Aid or what?
I'm not drinking the Kool-Aid, but actually, as you guys were just talking, I was kind of looking on PubMed. I'm going to have to keep looking, because I think there's a paper that talked about one of the advantages of an internal brace is earlier weight bearing. I don't know what your weight bearing status is after repair or reconstruction. If you protect their weight bearing, I do. But I'm going to have to look for that paper, because I think there was a paper that basically was saying, hey, here's a reason for an internal brace. You're going to let them, walk a little earlier. And especially if it was someone that you're really worried about their compliance, they're heavier, they're, bigger person, whatever, if they're going to be weight bearing on it, it might give you a little bit, maybe feel better and sleep a little bit better. But stay tuned. I'll look for that after. So that actually does bring us to weight bearing. So Brett, what do you do for weight bearing? Does it differ between a repair versus a reconstruction?
No, we have one MCL protocol that is pretty similar to our meniscus protocol with a progressive weight bearing. I think it's first 2 weeks non, and then 25, 50, 75 progressive weight bearing, with addition to similar 0 to 90 in the first 6 weeks, with progressing on past that. So I know the meniscus one is always very controversial, even in my practice. People are always going back and forth on how aggressive to be, and I get that. I know that more accelerated protocols have been shown to have value. In general, I tend to try to be a little conservative, because if I tell my patients that they can walk, then I've had some that are out, running, right? If I tell them they can run, they're playing basketball, right? And so I think I want to kind of keep them caged for a little bit in this first couple of weeks. Let it begin to heal in. Again, it all depends a little bit on what else you're doing. If it's if you're more worried about stiffness, if you're doing a concomitant, meniscal work or ACL or multi-leg situation.
Yeah, Ashley and I talk about the meniscus weight bearing all the time, because I think we've both changed over time. I know I've been I used to be extremely strict. I'm a little bit more lenient, but not lenient. But I also feel like, there's just not a lot of consensus. So Ashley, what do you do for your MCLs for weight bearing?
Yeah, so am a firm believer that whatever I tell my patients that they're allowed to do, they're going to take it one step further. So I'm very
Exactly.
conservative. And I think that might be why, I'm adding that internal brace, because I think most of the time that we're repairing these, at least again, in my population, it's a lot of football players. So it tends to be like larger linemen where like, even if they're partial weight bearing, they're weight bearing more than I am through my joint. And so I think it gives me that added comfort. So I do protected weight bearing, toe touch weight bearing for 2 weeks. Then I advance to partial and then full at 4 weeks in the brace, locked in extension. But I start them in PT immediately, 0 to 90 for the first 2 weeks, and then full thereafter. I really push the motion because I worry about stiffness. And I set those goals. They won't hit those goals, but I really aim for them to try to advance their motion because the number one concern I have is stiffness.
Yeah.
Catherine's going to find this a citation. She says that you can put one piece of string there, and they can weight bear immediately.
Exactly. I'm going to pat myself on the back for being the all-knower that puts in internal braces in the MCL. Awesome. Well, while Catherine is searching for that, we talked about like your repair and your reconstruction protocol being very similar. So how do you decide between repair and reconstruction? Is it duration from injury? Is this a surgical decision you're making? You talked about like adding a graft if it wasn't coming together well. Like, how do you make that call?
Yeah, I like to make the call beforehand, usually. I mean, in an acute situation, I try to do a repair. In theory, it's pretty rare that I'll have a case like this, but I have a few where it's torn at 2 locations, or it's truly a mid-substance type tear, it's high grade, and maybe you're going in for another reason, and you have to do a repair, and I'm basically prepared to have a graft available. And most of my reconstructions are more in the delayed surgical approaches. I guess I was just responding to your scenario where you didn't feel good about your repair, and you can add a graft if you've had them consent at least for that beforehand. But most of my reconstructions are more chronic situations. I try to treat my ACL-MCL. Is it okay if we talk about ACL-MCL? Is that where we are?
Good jumping point. So
okay. Yeah, I mean, I try to treat them unless we have one of those absolute or relative indications for early surgical interventions, such as a tibial-sided injury. I tried, or other meniscal situation. I try to give them 6 weeks to heal in, so we can get the MCL to heal and just address the the ACL. It is. There's a lot of level 1 evidence looking at this situation, and really doesn't show a benefit of addressing the MCL. It doesn't seem to make a difference. I know in my hands, being responsible for the ACL security, I do want to have security of my collaterals, and I want to make sure my MCL is solid. I usually make my decision pre-operatively. I'm one of those guys that likes to figure it out beforehand, right? Maybe not in the holding area, but in the in at least in my EUA, I want to have a decision and not wait till my ACL graft is secured. Find that everyone's different about that. I'd love to hear you both on how you approach that, but I always find that maybe I'm biased there then based upon my ACL fixation. But I like to make my decision. Hey, this is too loose still. It's been too long, and it's not getting sticky, and we have to usually it's a repair in that scenario. If it were a unique scenario and I need to add a graft, I would add a graft.
Found the paper.
Okay. Welcome back.
Basically, there's really no data. It's more of an opinion, I would say. So it was out of HSS. It's more saying, hey, you should do this as a technique. It was an arthroscopy because it allows them to weight bear immediately. But I don't see a reference that says because this biomechanics study was performed or anything like that. So
are there any financial disclosures of the offer?
Probably.
Okay.
So probably, but you can find that article, and I would guess you'll say yes. But yeah, they do weight bear right away because of that brace. So I think that's what I was remembering. But I don't see any actual data to back up why. So,
But it's interesting, right? You have this opinion paper out there, and it's stuck in your head. I don't know. It would be cool to look at biomechanically, I think. I mean, I think that is interesting. It's just there's so much load, as I think is actually alluded to, these big linemen, there's a lot of load across the MCL, and anything you can do to help is great. I'm just not completely sold on isolation all the time.
Yeah. All right. Well, I got sidetracked there, so sorry about that. But
That's okay.
I think you're talking a little bit about ACL, and I think, did you guys talk a little bit about graft? If you're talking about that you will use allograft, correct? If you're going to do a recon for MCL?
I am now almost completely allograft. Yeah. I mean, I think earlier in my practice, I would use it, I would use an open-ended stripper and keep the usually the semi-T attached, and then swing that up. And you can also, I know as Leprot has described, make it a little bit more anatomic with an anchor at the tibial footprint first. But I feel fortunate, being practicing in the U.S. where we have allograft available to us, and that these hamstrings are secondary stabilizers medially, and at least for me, I usually would like to preserve them if I can, and use a semi-T allograft usually.
Yeah,
and I've been all over the place. I started with like an Achilles graft. I started with all these different grafts, and for me, I use a double-limbed semi-T. So,
Ashley, are you using allograft or are you doing auto?
Yeah, so typically I haven't had many where I can't repair them, because I think we've spoken about we see these right as soon as the injury comes in, ACL, MCL, I'm getting them into PT that day or the next day, 3 times a week. And so with prehab, I'm usually able to get to them within that 2 to 4 week window. And so it's still typically repairable at that point. I know we've discussed this, and Brett, I'm interested to hear your opinion on this about whether there would ever be a scenario where you would take someone to the OR, repair the MCL, and then come back for the ACL. I think you kind of already answered that, saying if you just couldn't repair at the time of the ACL, you would do a reconstruction. But I'm wondering if there's any tear type that would push you towards that. But I haven't had to do that. So if I do a reconstruction, I typically will do an allograft, and I still use Achilles allograft, just how I was trained in fellowships, that's what I'm using, but it's super rare for me to have to do that.
Yeah, I mean, that is a unique scenario. I with an ACL-MCL, I don't think that I usually do. In a multi-lig situation, I certainly have. And I've had a few recent ACL-MCL PCLs, right? That it all depends on the scenario and how acute it is. And sometimes in a multi-lig situation, you have a huge soft tissue stripping. And I remember one in particular that had a lot of soft tissue injury, and we did just the MCL first. I think it might have been also patellar tendon involved, right? And fix that first, and then delay and do cruciate later. So I think that there's never and never and never and always, I guess, in addressing these.
We did talk a little bit about return to play testing already, because I know we're getting close to the end of time. So one of the other things we want to touch on, do you ever do screening for psychological readiness with MCL? Like, we talk about it so much with ACL. Are you seeing those sort of, for lack of a better word, like hesitation, nervousness, anxiety about returning to play in MCL without the ACL?
No, I'm not. This is, it's also amazing how much, for lack of a better word, slop is tolerated in MCL injuries, right? I mean, we all see, I take care of professional hockey players, and it's wild. You see these loose MCLs that, oh yeah, I tore that back in school, and especially with skating, it's so MCL dependent, right? And you see some of these chronic injuries that are tolerated to have this, sometimes even up to grade 2 kind of side-to-side difference with no symptoms at all, right? And I don't see a lot of apprehension or anxiety or kinesiophobia like you do with the cruciate injuries. But I also don't do as good of a job of following them, right? So most MCLs seeing you in the office maybe once, right? And then they're being managed by their therapist, their trainer. And that ACL that again, it's a surgical thing too, right? But you're following them, out to a year, right? And you really have that strong relationship and the time to really talk about the psychological impact and return.
Yeah. I also think hockey players are a little, they're just like, whatever, it's not a big deal, for a lot of
Tough
things.
as nails.
Yeah.
They really
I
are.
had a kid today. He plays AAA, out of state. I'd seen him in the past. I know the family well because my kids play hockey, and he had like a grade 2 AC, and was counseled sort of out of state. Oh, surgical. You're definitely going to need surgery for that. I saw him in clinic, this week. He's home for Thanksgiving, and I was just saying, hey, you're going to have a bump there. You don't need surgery, but it's just going to look like that. And he said, yeah, I saw my coach yesterday, like his local coach. And he basically,
who has it too, right?
And he wanted to see mine, grade 3.
He was like, see mine, exactly. Yeah. Yeah, they all have it, right? I mean, yeah.
So yeah, they're funny that way. But anyway, but yeah, Ashley, do you have any differing opinions on psychological readiness? But I kind of agree.
No, yeah, I agree. I mean, I think if we're ultimately going to craft a formal return to play test like we did for ACL, we should include some component of that, psychological screening like they have at ACL, RSI, especially for the surgical ones. But I think for the non-operative treated ones, I think they do really well. So I think that I don't worry about it as much. I think if biomechanically they seem optimized and ready to get back in, I don't worry about that as much. But I do think that's the future with all of our surgical injuries. I mentioned shoulder instability, ACL, some of these major injuries. I think we need to be looking at psychological fear of re-injury in terms of being prognostic of potential re-injury. So I think that's something important. And then we need to come up with interventions. We've spoken about this, Catherine, that you can't just identify there's a problem, that then who do we refer them to? Where are the sports psychologists? What programs can we get them into? When should we be identifying this? Should we be identifying it pre-op and be working with them through? So I think there's a lot to learn in this realm.
Kudos to you both. It's an area that we really need to advance in.
Yeah, no, agree. All right. Well, I think we went, front to back to MCL, but we always end with our fast 5 questions for you. So get ready.
This was good. This was a the stepchild of knee ligament injuries, and I think we tried to make it as exciting as we could.
You did a great job.
Yeah,
you did. Yeah.
No, you're obviously an awesome guest, and we're lucky to have you. And also look forward to pulling you back in for AOSSM to hear updates on the BEAR trial, because there should be a lot more data at that point, and I think it'll be really great to hear it and see what you have to say then too.
Love to.
Absolutely.
Okay. Yeah, we make you promise. All right, Ashley, you want to kick it off?
Absolutely. So in the OR, do you use foot pedal or hand control?
Hand control.
And that's for everything, for like shaver, burner, all that stuff.
Everything. I have the sore thumbs to prove it. Yeah.
Yes, exactly. Me too.
All right. What shoes do you wear in the operating room?
I wear knee-high boots. Always have. People make fun of it all the time, but even today, someone said, "Hey, Doc," and where I am, like, "Hey, Doc, you going call hogging?" They think I'm going off clamming or something, and but yeah, it's I always wear the knee-high boots.
You are not in the minority. So Mary Mulcahy, I don't know if you saw this, Catherine, on Twitter, posted a picture of her in rain boots with one of her, I think a student that was with her, and was like, do you wear rain boots in the OR? And tagged a bunch of us. Catherine, you were tagged in it too. And people were answering like, yes, of course. Yes, real sports surgeons wear rain boots. And I was like, I guess I'll be the minority that says I wear my clogs with like the pullovers. And I was like the only person that admitted to that. Everyone else was like, you're not a real sports surgeon if you don't wear rain boots. I was like, crap, I should like delete my response. This is so intense. So everyone seems to be wearing rain boots, so you're not alone.
I wear like tall hunter boots, but they have a wedge heel. And so they're like pretty stacked because like when you're a resident, everybody was so much taller than me and I didn't want to use the step stool. So it was just with the table height, I could use that wedge heel and I'd be fine. And then when I was like finishing up residency, Hunter stopped making those. So I went and like, if you go in my garage, there's like 5 pairs of brand new ones, like just ready. So I have them for my career.
That's awesome. That's forward thinking, Catherine.
Yeah.
All right. So what is your favorite OR lounge snack?
That's a great question. I usually bring my own snack. So, maybe a cup of coffee.
Yeah, that's
Pretty
me.
boring.
Yeah.
Yeah.
I actually, when I was in between cases today, I got a coffee and it was just like perfect. It was so good. And I was like, just like walking and I probably only got to have like, I don't know, a third of it. And I just like had to throw it out and I was like, so mad. But that's my in between too. So what music do you play in the OR?
Yeah, we're kind of all over the spectrum. Yeah, we really are. I like to let my patients choose, and it's been ever since Taylor Swift dropped her new record. It's all my adolescence have been. It's been a lot of Tay. But I usually let them pick, right? If it's up to me, it's usually Grateful Dead or some classic rock. But my usual rule is the ABCs or anything but country. But I'll even do country if the team really wants it. We try to make it so that the team is really supportive. The question I'll throw back to you is when is it acceptable to play Christmas music? Do we have to wait till after Thanksgiving? Is it only Christmas Eve? When is it acceptable in your ORs?
Ashley,
I am obsessed with Christmas. I would start it in like September. Obviously, that's not socially acceptable, so I don't do that. But after Halloween, so I just played it for 2 of the 5 cases today. But it's funny because since you told Catherine and I in the past that you let the patient choose, I've been trying to do that. And so my PA was obsessed with Taylor Swift. And we had all young athletes, all young female athletes, 14, 15. I was like, you're going to get Taylor, Anna. You're going to get her. And they settle in, and everyone doesn't like country in the OR. And so they settle in. I'm like, all right, well, what do you want to listen to? And she's like, I love country. And everyone's like, no. It was like, we reached the end of the day. No one requested Taylor. Anna was devastated. It was a bad ending to the day, but maybe next time. But yeah, we listen to Christmas.
You'll learn a lot by letting them do it, by letting them pick. I learned loads of new bands, and last year I had this kind of older cuff woman who we gave her a choice. It's just sweet older woman, and she looks at us and she says with a real raspy voice, ACDC. And we all couldn't stop laughing, and we listened to ACDC the whole case just for her. So
that's awesome.
Yeah, it's always fun if they could pick.
Did you see that study that came out? I'm trying to remember. Was it in New England Journal? I'm trying to remember. It was about music in the OR and who's most productive. Like as far as I think they looked at like efficiency and maybe even turnover time. It was just all these sort of like generic metrics because it was across all different surgical subspecialties. And it was ACDC.
Really? Catherine, we have to cover that. We have to cover that article in one of our mini episodes. That'll be so popular. I haven't heard of that. That's awesome.
I'll find the paper. It's really good.
Nice.
That's great.
Yeah. And then, okay. Your turn. Go ahead.
Favorite surgery.
Yeah, I have to say an arthroscopic Bankart repair is probably my favorite.
It's like very rewarding.
Hard to beat that, or a nice BTB ACL. It's hard to, if I could just do those 2 the rest of my career, I'd be a pretty happy guy.
Yeah, nice. No, good point. All right, so we do something where you're going to propose a question to our next guest, and someone has already proposed a question for you. So your question, okay, I think you know him, comes from Dr. Matt Provencher.
Okay.
And he wants to know, why do you think collegiate rowing athletes are far superior to lacrosse players?
Collegiate rowing athletes. Okay, that's if Matt were here, I'd have to challenge his use of rowing athletes. But Matt's a former rower, and I have a lot of respect and friends that are rowers. And I would have to say, no one's tougher than lacrosse players. But if a college rower were tougher than a lacrosse player like Matt, it would have to be to his superior grit and resilience.
Yeah, I
That's
agree. All right, and then you are going to propose a question to Dr. William Bugby, who's going to be doing an episode of OCA, so osteochondral allograft.
Well, I mean, you have the expert on. That's super exciting. I don't know Bill well, but I'm a big fan of his work, and I think it's going to be exciting to see what he has to share. I do a lot of fresh OCs usually for condyle lesions. I think I'd love to see. I still kind of lean on Macy because I've had some really rough experiences with patella. I guess that would be my question. It would be teach us some advice for treating the patella with fresh OCAs, and maybe the trochlea too. And patellofemoral joint would be a really interesting area to look at. I know some people, first Tom DiBerardino does these huge, like complete resurfacings of the patella, like where he can take, I don't know, I've had some bad experiences where you don't know the thickness of the graft and you put in a graft with a different thickness. And I've had some failures with a plug, right? And those are a little tricky. So I think if it's unless there's a bony reason to do so, it's actually the case I really like to do a Macy for.
Yeah, agreed. No, great question. Yeah. All right. Well, thank you so much.
That's gonna be a really good session. I'm excited to hear that. He's super. That's great. I had so much fun today. This was a lot of fun.
Thank you. No, we feel really lucky to have you and appreciate you taking so much time with us.
Yes. And we're really excited to get you back at AOSSM and have you kind of give us an update. As Catherine said about that bear trial, we're really excited to see some of those results. So hopefully you let us in on some of the early results at AOSSM.
That'll be great. Thank you.
All right, awesome.
Thank
Have
you.
a good night. Thank you for listening to this episode of the Sports Talks. We hope you enjoyed this discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkspod@gmail.com or find us on Instagram at thesportstalkspod and Twitter at thesports.pod. We love your feedback.